and the program.
Yeah, it's a great honor for me to present my experience at your retirement web seminar. Yeah, thank you. Thank you for inviting me.
Well, thank you. And I also noticed you actually put the, your poster in your Facebook. And I watched that and I hit, oh, great.
Did you see that? Yeah, you put, yeah, I checked that.
Yeah.
Yeah.
So at what time you usually start your work?
Yeah, 8:30.
8:30.
Yeah.
8:30. So now it's 7:30
Japan.
In Japan. Yeah, 7:30. So 1 hour earlier. Thank you.
Yeah. So yeah, now in Japan it's 8:30.
Oh, in Japan it's 8:30.
Yes.
Oh, okay, 1 hour. Yeah. I'm very confused with the time difference.
Yeah, our time is 1 hour earlier than yours. Yeah.
How about the weather in Kobe now?
Yeah, good. So it's so last week it was very cold, but now yeah, but today I think it's getting warmer. Yeah. Do you know the cherry blossom?
Yeah.
Yeah.
Cherry blossom now is just last week and 2 weeks before. It's very beautiful. How about in Japan?
Maybe at the end of this month, maybe. Yeah.
At the end of this month.
Yeah.
You know, we just passed our Lunar Chinese New Year, and most of my friends were in Japan.
Yeah. Thank you for visiting our country.
Yeah, so, I still remember the hot spring, the onsen.
Arima Onsen.
Arima Onsen.
Yeah, it's one of the oldest and most famous. Yeah.
Yeah.
It's very close to our university and my home. Yeah.
Yeah. I still remember that, and thank you for treating me, some years ago. Yeah. Arima Onsen.
Yeah, right.
Yeah. Yeah. Have you been to Yangmingshan in Taipei City? Have you been there? Yangmingshan, Yangming Mountain.
Yeah. Maybe in the Taiwan, Japan, after Taiwan, Japan EMT conference. Maybe maybe more than 10 years ago.
Oh, more than 10 years ago. It's very convenient for us because it's only half an hour from my hospital.
Oh. Just
so I could drive even when I do the surgery, when they change the patient, and I could go to the Yangmingshan and then come back. it's very, very close to my hospital.
So your house is also close to your hospital, your home?
Yeah, not usually 25 minutes drive. 25 minutes drive. But my hospital is in Shilin district in Taipei. So it's very close to Yangming Mountain, right at the root of Yangming Mountain. Yeah.
Oh, it's located in the mountain, right?
At the root of the mountain.
Okay.
There is a famous night market called Shilin Night Market in Taipei. My hospital from that night market. Yeah. The Xinguang Memorial Hospital. Yeah. And now it's 7:30. So I'm sorry to interrupt you, but I think we should start. And my son Peter, he is going to be your moderator. So Peter, please. Yep.
Yes.
Yeah, let's get started. Peter, we could not hear you.
Good morning and good evening, fellow doctors and colleagues. For the second portion of Dr. Sheng-Po retirement virtual webinar. We're honored to introduce Professor Ken-ichi Nibu as our invited speaker. Professor Nibu graduated from University of Tokyo and completed his fellowship in the Department of Head and Neck Cancer Hospital, Tokyo, in Japan. He also attended Thomas Jefferson University in Philadelphia, USA, as a Biden researcher. Professor Nibu is currently working as a professor and chairman of Department of Otolaryngology, Head and Neck Surgery at Kobe University Hospital. He was elected as a president of Asian Society of Head and Neck Oncology from 2015. He is currently the president of Japan Society for Head and Neck Cancer and vice president of Japan Society of Otolaryngology, Head and Neck Surgery. Today, Professor Nibu's presenting topic is photoimmunotherapy and Boron Neutron capture therapy. Please give a round of applause to welcome Professor Nibu.
Yeah. So thank you, Professor Hao, for introducing me very, very precisely. So I would like to share my slide. Okay. Oh, this is a conclusion. Sorry. Okay. Okay, thank you, Professor. Good morning, Professor Hao and my colleagues. So it's a great honor for me to talk about several topics at Professor Hao's retirement virtual web. So today I would like to talk about the non-surgical treatment for head and neck cancer made in Japan, I mean, developed in Japan. So this is my CV. So as you know, in the treatment of the cancers in head and neck, we are expected to improve survival, and at the same time, we are requested to preserve various functions and appearance. So to address this issue, multidisciplinary treatment, including surgery, radiotherapy, and chemotherapy have been developed for head and neck cancer since 1960s. So recently, more diverse treatment options have become available, including minimal invasive surgery using endoscopy and surgical robots, and molecular targeted drugs, and immunocheckpoint inhibitors, and particle beam therapy. So among the various treatments, today I would like to talk about head and neck photoimmunotherapy and boron neuron capture therapy, we call BNCT. And yesterday, Professor Hao asked me to talk at least 30 minutes. So that's why I will talk on another topic too at the end of my talk. So, Professor, how do you remember this photograph?
Yes, of course.
Yeah. So the Aluminox platform is a newly introduced cancer therapy called photoimmunotherapy, which was developed by Dr. Kobayashi of the National Cancer Institute in the United States. So actually, Dr. Kobayashi is 1 year behind me in my high school. Yeah, so we are alumni. So he also grew up in this area in Kobe. So 3 years ago, so this treatment has been approved by Japanese government for unresectable locally advanced and recurrent head and neck cancers. So for head and neck cancer, Acarux is applied. So this slide shows a detailed structure of Acarux cetuximab. An antibody against EGFR is conjugated with photosensitive substance IR700. So when Acarux is administered intravenously, Acarux binds to EGFR expressed on the cell membrane of cancer cells. When irradiated by a laser at the wavelength of 690 nanometer, dye IR700 contained in the Acarux reacts to this laser light and produces a photochemical reaction. So this photochemical reaction makes perforation in the cell membrane of cancer cells. As a result, cancer cells die. So please watch this movie.
A Luminex platform is Rocket and Medical's proprietary precision anti-cancer photoimmunotherapy technology, which combines the power of light with drug and device components. The drug component consists of a cell-targeting moiety conjugated with one or more dyes that selectively binds the surface of target cells. Illuminating the targeted cells with non-thermal red light activates the cell-bound drug, which leads to rapid and selective cell killing. Tumor-targeted treatment based on a Luminox platform is initiated with intravenous infusion of the antibody conjugate that distributes systemically and accumulates at the tumor where it attaches to specific antigens present on the surface of tumor cells. After infusion of the conjugate, the tumor is illuminated with non-thermal red light to transiently excite the antibody conjugate to elicit anti-cancer activity. A laser is used as the light source. Superficial tumors are illuminated with frontal diffusers. Deep subcutaneous and large tumors are illuminated with cylindrical diffusers inserted into catheters placed using image guidance. Total illumination lasts about 5 minutes for each treated region. Antibody conjugates bound to the antigen on the cancer cells are transiently excited upon non-thermal red light illumination to induce a biophysical process that compromises the membrane integrity of cancer cells, leading to cancer cell death and tumor necrosis with minimal effects on surrounding normal tissue.
So Acarux is infused intravenously over 2 hours on day 1st, and the next day the tumor is exposed to the red light illumination with a wavelength of 690 nanometer using a laser system. So this is a laser system for head and neck photoimmunotherapy we call BioBraid, and the frontal diffuser for superficial tumors, and the cylindrical diffuser for invasive tumor. So this slide shows a waterfall plot of best change in the diameters in the phase 2 study. As you can see, the complete response or a partial response were observed in half of the patients. So median overall survival was 9 months in phase 2 study. So bleeding from the tumor is the most serious complications. So cases involving the carotid artery should be considered as contraindication. So edema in larynx or tongue and severe pain are most common postoperative complications. So management of airway and pain are crucial in this treatment. So now head and neck photoimmunotherapy is available in nearly 100 hospitals in Japan, and over 400 cycles were performed in our country. So according to the post-marketing surveillance in Japan, so far, complete response or partial response were obtained more than 60% of the patients. So now I will show you the representative case in our hospital. The first patient is a 70 years old lady. So she was treated by chemoradiotherapy for oropharyngeal cancer as an initial treatment. So complete remission was obtained, but local recurrence developed 16 months after chemoradiotherapy. So since recurrence was limited in the lateral base of the tongue, we decided to apply photoimmunotherapy to this patient. So the next day after the administration of Acarux, illumination was performed under general anesthesia. So the needle catheter was carefully inserted by palpation. And then cylindrical diffuser were inserted into the needle catheter. And now cancer cells were eliminated about 5 minutes. So complete remission was confirmed by PET-CT and endoscopic examination. Now I would like to move to the next topic, BNCT. So boron neutron capture therapy, BNCT, is a treatment method that combines boron with neutron beams. The principle of BNCT is that the boron absorbed in the tumor cells reacts with neutron beams. So this nuclear reaction destroys the cancer cells. The neutron beam itself is very low energy and has almost no effect on the human body. However, when neutrons hit boron, a nuclear reaction occurs and alpha particle and lithium nuclei are produced. Since this reaction is limited within the cells, nuclear reaction can selectively destroy tumor cells that take up boron, but not surrounding normal tissues. So BNCT was first proposed in the United States in 1936. So it's a long time ago. So since then, clinical studies have been conducted in Japan using nuclear reactors. That's a very large facility. In 2008, an accelerator for BNCT that can be installed in hospitals was developed in Japan. So, and in 2020, so stavoloning boron was approved by Japanese government, and now BNCT is covered by public insurance in our country. So in BNCT, boron is administered intravenously for 2 hours, and then neutron is initiated. Since the blood concentration of boron decreases quickly after its administration, the boron is also continuously administered during irradiation. So this slide shows the irradiation doses in BNCT in tumor and normal tissue. So since nuclear reaction is limited in the individual tumor cells, irradiation dose of normal tissue is significantly smaller than tumor tissue. So it is so far, survey forms of 179 patients treated by BNCT were accumulated. 25% of the patients were treated for neck metastasis, and 66% of the patients were treated for primary recurrence. So in principle, distant metastasis is contraindication. So this slide shows the results of the best response of the targeted lesion site by site, 6 months after BNCT, and 1 year after, and 2 years after BNCT. So although follow-up period is not enough, but promising oncological outcomes were obtained so far. So now I would like to show you one of my patients treated by BNCT. So last summer, this 40 years old, this 40 years old lady underwent subtotal grossectomy for recurrent advanced tongue cancer in our hospital. So unfortunately, she developed recurrence in nasopharyngeal area. So after 4 courses of chemotherapy, she underwent BNCT at Kansai BNCT Medical Center. As shown here, the complete remission was obtained. And she has been alive without disease more than 1 year after BNCT. So now I would like to go to the last topic, the non-surgical treatment for maxillary sinus cancer. So this is a brief outline of blood clot, super-selective arterial infusion of high-dose cisplatin with concomitant radiotherapy. A catheter is inserted from the femoral artery, and cisplatin is administered from the catheter positioned in the region of the expected blood supply. Simultaneously, sodium thiosulfate was infused intravenously to neutralize the cisplatin. So cisplatin is administered up to 6 times during radiotherapy. So the key to success is to complete jigsaw puzzle using CT angiography. So for example, the blood supply of this tumor came from left maxillary sinus, maxillary artery, left facial artery, left transverse facial artery, and right maxillary artery. So in the original protocol, cisplatin was given in the first, second, third, and fourth week concurrently with radiation. However, recently, we also give in the 5th and 6th week if possible. So in 2013, Professor Honma of Hokkaido University reported quite favorable oncological results of the patients treated with ladoprat. The 5-year overall survival rate of the patients with T4 disease is around 60%. So encouraged by their exciting results, we started blood plot at Kobe University. So far, we have treated 45 patients with maxillary sinus cancer by blood plot. And male is predominant, and most of the patients had advanced disease. All the cancers were histologically squamous cell carcinoma. The 5-year overall survival rate of the patients was 69%, and 5-year disease-free survival rate was 65%. Almost all the patients with T2 and T3 diseases have been alive without disease. On the other hand, all the patients with T4B disease died of disease. So treatment for T4B needs improvement. So another issue in blood plot is the tumor fed by branches of internal carotid artery. In blood plot, cisplatin is administered by external carotid artery system. However, the targeted regions are occasionally fed by branches of internal carotid artery. So in such cases, local control may not be achieved by blood plot with a standard procedure by external carotid artery, since cisplatin is not sufficiently delivered to the regions fed by the ophthalmic artery. So in such cases, we ligate ethmoid artery. In the patient, regions extending to the anterior ethmoid was enhanced by the contrast media infused by an ophthalmic artery, but not by a maxillary artery. After ligation of the ethmoid artery, internal carotid angiography revealed no contrast effect on the tumor, like this. By this procedure, entire tumor was fed by the branches of external carotid artery. So blood plot by external carotid artery successfully controlled these diseases. In case where ligation of ethmoid arteries cannot indicable due to extensive invasion, we administer cisplatin via ophthalmic artery if the patient wishes to preserve orbital content with understanding of high possibility of visual loss. So in summary, head and neck photoimmunotherapy and boron neutron capture therapy are promising new treatment strategy for recurrent unresectable head and neck squamous cell carcinomas. So although blood plot requires techniques of interventional radiology and it's very time-consuming, blood plot is useful to preserve appearance, organs, and functions in patients with advanced maxillary sinus cancer. So in conclusion, so thank you, Professor Hao, for everything you have done for us. We are what we are today, and I am what I am today because of you and your strong support. And congratulations on your retirement. So we wish you and your family eternal health and happiness. And we are looking forward to your continued guidance and encouragement. Thank you for your attention.
Thank you, Professor Nibu's fascinating talk. We open to the floor to our colleagues or doctors if there's any questions or discussion with Professor Nibu.
I think this is really very brand new idea of non-surgical therapy for head and neck cancer. Although most of the cases were actually unresectable or recurrent head and neck cancer, and I think there are many people, many participants, not only from Taiwan, but also participants from all other parts in the world. And so I guess this new therapy might be a very brand new challenge for all the countries, not only in Asia but also in the whole world. So I wonder if this is really practical in some part of the world. For example, in Taiwan, I think the nuclear reactor, we think of nuclear reactor, will be very afraid of. And so, and I think, and I believe the patient selection might be a challenge as well. So Nibu, Ken, do you have any comment on this? How we, because you have so many tools in your hands, so how could we select a right, weapon for our patient? For example, for a resectable but advanced head and neck cancer, that's first one, and then second one unresectable, and then the third one the recurrent head and neck cancer. And so what's your selection, and what's your comments or suggestions? Thank you.
Thank you for your comments and questions. So so for the in the BNCT, we used to use a nuclear reactor, but now we do not use a nuclear reactor. That's we need a big equipment. Now we use equipment for the PET. So it's a very compact and cheap and safe. So now the company Sumitomo Industry trying to sell this machine to your country too, maybe. All over the world. So for your question, so if it's resectable and the patient want to accept to have surgery, we recommend and we treat our patient by surgery. And if it's not resectable or a patient wants the organ preservation surgery, we treat them with chemoradiotherapy. And if the patient have unfortunately multiple disease in the head and neck area and also the distant metastasis, we treat with chemotherapy or immune checkpoint inhibitors. And if the patient have a very limited local recurrence in the primary site or the neck, we recommend them to have photoimmunotherapy or the BNCT. So actually, the president Mikitani, do you know the president of the Rakuten Medical, and I think that Giants and Rakuten have a game yesterday in the baseball in your country. So the Mikitani grew up in Kobe.
Oh.
And his home is in Kobe. Hometown is Kobe. So we are familiar with each other. So the tumor is very limited and it's located in the surface and or located in the oral cavity I recommend photoimmunotherapy. But it's in the deep side, I recommend BNCT. Yeah.
Thank you. Any other questions?
Yes, this is Dr. Yan from Taiwan. I'm a radiation oncologist and old friend, good friend with Professor Ho. And because in Taiwan, I'm really appreciate that Professor Nibu's presentation, especially including very excellent result from Japan in BNCT. The initiator and the promoter from clinical part for Taiwan's BNCT development. But I want to emphasize that Professor Ho, that's almost at least 14 years ago, because his excellent achievement in head and neck cancer treatment. Our BNCT project initially should be audit reviewed by Taiwan FDA, and Professor Ho is one of the professional people to site visit our project, and by his understanding about the BNCT, that's very helpful in the head and neck cancer. So he strongly support for this. That is one of the reasons that our BNCT project can be substantially developed in Taiwan in past 13 years. Because Japan is has accumulated the most number of BNCT patient treatment in the world. Then in the past 13 years, Taiwan is the second number. We have already treated around 400 cases, including head and neck cancer and recurrent GBM. But the first project started from 13 years ago. That's recurrent head and neck cancer. I'm the promoter. I have distributed this website to my colleague, Dr. Wang Lingwei. I don't know whether Dr. Wang Lingwei is also here or not. He conducted this treatment. Initially, I spent 4 years, 17 cases, phase 1, phase 2, and randomized cases. I think probably many of you have read that that's reported in Red Journal in 2016. And our response is similar, like your report in Japan. And the response rate, almost 70%, 70%, CR rate more than 36, partial response at least 1/3. The result continues to be presented for the future case, but I think Professor Ho have good cooperation and really understand the effectiveness, the contribution for the head cancer patient. I wanted to express my appreciation for Professor Ho's retirement. I don't know what kind of retirement. He's still so young. That's officially retirement for administration work, but substantially he will continue contribute his professional expertise in this field. Congratulations to Professor Ho. Thanks.
Well, thank you, Professor Yan Shanhui. Thank you for your compliment. Really honored to audit or to review your program in BNCT some years ago. And I really learned a lot from you, and thank you for your comment as well. And I think Professor Nibu, you also gave us a brand new idea, a brand new way to think of how we should treat our patients. And I don't know if there's still a lower for non-surgical treatment, such as immunotherapy, photodynamic therapy, photoimmunotherapy for newly diagnosed, untreated head and neck cancer. Is there a lower for this? It seems to me it's only for superficial lesions initially for photodynamic, but now you also could use the catheter, just like radiation therapy, intracavity radiation therapy, or the intratissue radiation therapy. But now you apply that kind of technique for the treatment for photoimmunotherapy for some more extensive or more deeply infiltrated tumor. And I wonder if this is really practical and how you could calculate. I think the problem might be how you could calculate the tumor coverage area. I think that's also the problem for in the past for the radiation oncologist to calculate the energy deliver, how to prevent the subsequent radial necrosis or something like that. You have any comment on this? Is this only for superficial lesion, or is really practical for deep lesion as well? The photoimmunotherapy.
Yeah. So the best indication is a superficial disease. So if the tumor is arising in the oral cavity, embedded to your face skin, if you treat with speed, you make a perforation through the oral cavity and face. So the very embedded disease is not good for this therapy. Yeah. And also reaction is very quickly. So you will have a perforation within 2 weeks or 3 weeks. So I do not recommend for the advanced disease. So this is best indication is a superficial disease. Yeah.
Thank you.
And for VNCT, you can apply to the irradiated area. Actually, in Japan, the public insurance only covers for the patient previously irradiated.
Oh, previously irradiated, not previously operated.
Yeah, previously irradiated and previously operated.
Okay.
So we cannot use for the non-radiated disease. So the government asked us to try to treat with radiation and chemotherapy if you can treat by surgery. Yeah.
Thank you. Any other questions?
Similar indication in Taiwan.
Yeah.
Yeah.
Yeah. So Professor thank you for your comment. Thank you very, yeah.
Yeah, I think the time, if there are no question, I would love to thank Professor Nibu for your great support. I think Taiwan and Japan has been very close, and Professor Nibu is also my best friend from Japan. So we have been cooperating with each other. We have been working with other you and me, and to work for the global otolaryngology education. And thank you again for your great support. Thank you, and I wish to see you in some other meetings. Although I just stepped down from the chairmanship, but I will still keep on my clinical work as well. So thank you so much today. Thank you. Yep.
Thank you.
Yeah,
such an opportunity. Thank you. So
thank you.
In touch.
Yeah, keep in touch. And I'm going to move on to do a small, broadcast for tomorrow talk. Tomorrow, can we have the next slide, please? Tomorrow, we are going to invite Professor Passari from. I'm going to invite Professor Passari from Italy, and he is a past president of the IFOS, and has been a good friend with Taiwan and with me as well. So looking forward to your participation tomorrow at the same time. So thank you again. Thank you, Nibu, for your wonderful talk, and have a good day. Thank you.
You too. Thank you.
Yeah, thank you. Bye bye. Keep in touch. Thank
Bye.
you.
Bye-bye.
You congratulations to Professor Ho.
Yeah, thank you. Yes, Professor Yan Shanghui. Thank you. Thank you so much. Yeah. Okay, we close the webinar today. Thank you. 现在几点了？那他要再开 morning meeting 吗？不用了是吗？啊，没有了哈。啊，要关掉哈。谢谢。